Good morning, good afternoon, good evening. I am Sabina Faiz Rashid. I'm the Dean and Professor of BRAC James V. Grant School of Public Health, BRAC University in Bangladesh. It is a great pleasure to be here today. And I'm extremely excited and very honored to moderate this very important plenary session on decolonizing global health. I'm going to go through this sort of the bios very quickly. If I could request, I've got everyone here, Anu, Sapna, Catherine, and Madhukar. Welcome. We're going to do quickly sort of the bios, and then we're going to actually have an informal discussion, a conversation with a couple of key questions. What I'd request the audience to do is post your questions, any comments, but we prefer some questions in the chat box. And we'll come to that at some point after we have some discussions amongst the expert speakers. So first of all, we have Anu Kumar, President and CEO at Ipas. Anu Kumar joined Ipas in 2002 as Executive Vice President. She's had oversight of Ipas's fundraising and communication efforts, started a new technical area working with communities, and pioneered work on abortion stigma. In 2016, she became Ipas's first Chief Strategy and Development Officer and led the organizational strategic planning process with fundraising, partnership development, technical innovation. But more importantly, I stumbled upon an article by, well, many important things you've done, Onu, but one of the most exciting features, and that's why I think you're an ideal fit for today's discussions, is this article Anu Kumar wrote about how she's restructured and reorganized Ipas to really move away these hierarchies of geographical spaces. And how do you define decision-making? How do you define headquarters versus other spaces that are more regional or national? So you've really unpacked those sorts of concepts in systems and tried to restructure it at Ipas. So I leave it at that. The next person is, and they're all extremely equally distinguished, but I'm just going along with whoever I'm looking at in my Zoom box. So I'm going to get to Sapna. Dr. Sapna Desai is an associate with the Population Council, New Delhi, India. We work closely together on the Sexual Reproductive Health Matters Journal. She conducts research, though, at the Pop Council on women's health systems, and community-based interventions. She's co-PI of the Global Evidence Consortium on Women's Groups, which works with partners across India, Uganda, and Nigeria. Yes, Sapna, we know you're very busy because she's co-editing a special issue, and we know how much work that is on South Asia for the journal Sexual Reproductive Health Matters. She serves on Lancet's India's COVID-19 Task Force and Citizens Commission on Reimagining India's health system. But what I find really interesting, and of course all that you do is very, very important, is the fact that you spent several years working in a grassroots health program called SEWA, India's largest organization of women workers. So your public health has really been driven by grassroots for several years before you moved on to Pop Council and other spaces. I'm not going to go into all the degrees that all of them hold. I think you can look that up when you look up their bios. Next, I'm going to throw in Madhukar to break it up with the women and now the man. Madhukar Pai is Canada's research chair in translational epidemiology and global health, associate director, McGill International TB Center, Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. He's a medical doctor, academic, I would say a real advocate for decolonizing global health, a writer and a university professor. Your work around, Pai's work is around global health, specifically advocacy for better treatment for tuberculosis with a focus on South Asia and India. Pai is the Canada Research Chair of Epidemiology and Global Health at McGill University. There's a lot you've done. Dr. Pai, Madhukar, I'm going to call you Madhukar. And just like Onu and Sapna, you and I met on email when you shared with me an article you'd written about global malpractice. And you mentioned BRAC James V. Grant School of Public Health as an ideal training ground for really community-based learning and trying to get a grounded approach to public health. And that's where my relationship, or at least my meeting with Madhukar happened. And then we have Catherine, Dr. Catherine Kyobutungi. I hope I pronounced it correctly. I have a lot of work with APHRC, African Population Health Research Council, but this is the first time I'm meeting Catherine, and I'm so glad you're making the time. So Catherine is Executive Director of APHRC in Kenya, and that's a leading institute in Nairobi. Catherine is a Ugandan epidemiologist, and you are a Joe Lang Chair. You were elected, she was elected to the African Academy of Sciences in 2018, formerly Director of the Center of Research. Catherine's been there for 15 years and, has been working very much in research and leading APHRC, and also very much engaged in the Decolonizing Global Health Discourse, working closely with Madhukar and in the journal, but I'm not going to talk about that now, like Sapna and Onu. So welcome, everyone. Thank you very much. I think what we're going to do is I should share, I'm a medical anthropologist, and I'm a dean and professor at the school. I've been working at the school for 19 years. I've been dean for 9 years and a professor since then. And I do a lot of work on community vulnerable marginalized populations, looking at social exclusion and marginalization and the language of marginalization, intersectionality, and it informs our teaching and our research. So how about we get straight into it? I'm going to just go across and ask you for about 5, 6, 7 minutes to share a little bit about your views. So one thing is, this plenary was very, very important for me, and I know for all of us, because of the kind of work you do, which is decolonizing global health. So I really want to start with Sapna. Sapna, I mean, if we look at decolonizing global health, I want to understand a little bit about what does that mean to you, and how can we explicitly create a space, for those who want to engage and learn and contribute in these spaces. You could share examples from your own work, from other people's work, or other colleagues or institutions or academics. Thank you.
Thanks, Sabina, and thank you so much for having me here. So I will confess the decolonizing global health conversations that I think everyone has been reading in journals and whatnot perplexed me quite a bit in the beginning, because I only work really in India. Though I work with partners in other places, I really only work in India. So I always wondered, should I even be part of these conversations, because I'm not really global, which really then got me thinking personally, who is a global health practitioner then, if I don't consider myself one? And I think that's where I want to begin in terms of my own sort of journey and trying to understand public health practice, and then how that then relates to decolonizing global health. And to me, at the heart of it really is our value systems and what we value in public health, and then by extension in how global health is formed. And I'll just give an example to start. When I finished my first degree in public health, I went and worked for a trade union, as you mentioned, Sabina, and did very grassroots work for about a decade. And nobody understood why I would spend so long on the ground when I could be working in a much more sort of, well-known international organization, be it in Delhi or in Geneva or New York, etc. And to me, that's the heart of it. What do we value in public health? Is it the technical? Is it the people that get to do the speaking, or is it the people that also do the doing and the practice? So to me, decolonizing global health really comes down to what we value. And I think our values are way too skewed right now, in how I observe it at least, towards those who articulate and the sort of synthesizers of information and knowledge, probably due to the type of training people have, as opposed to the practice. And I think that needs to be adjusted and reshifted. And I think we need to think about shifting that balance to really bring forth a conversation in which different types of people really engage in global health conversations. Because as you and I both know, Sabina, I mean, we've been going to these conferences, and it's really a specific type of person, even from our own settings from India and Bangladesh. It's people like us, as opposed to a much more diverse set of actors. So let's start with that.
Thank you. I think it's very interesting because you're bringing in how global health, particularly as we in certain spaces dominated by a sort of a certain group, academics or people who are articulate but may not be coming from sort of grassroots, who have actually the field experience, but are sometimes in many different ways excluded because of the way the resources and structure. But can I now go to, I would request Anu and maybe Catherine also to keep their videos on, because it's just helpful. I just thought maybe we could ask Catherine and then go to Anu, and then Madhukar, whoever wants to kind of come in and share a little bit. Maybe Catherine, would you like to share what it means to you and how do we create spaces, or we can come back to examples after this round?
Yes, thanks, Sabina, and thanks everyone for having me. I'm very pleased to be part of this. And I think I'm a recent advocate for decolonizing global health. But that's more from a branding perspective or from a positioning perspective. I work in an organization where I've been for more than 15 years. And for as long as I can remember, there was already some kind of understanding about inequitable partnerships and how they manifest and how they should be resisted, more or less. So I work in an institution where from the time I joined, there was always that kind of principles and values and culture around what are considered partnerships. So that really has been my space. And also this is an institution which we position ourselves as trying to elevate African voices in issues that affect Africans. And because a lot of African problems are not defined by Africans, and a lot of solutions to those problems are not defined by Africans. So we are sort of on the receiving end of constant problem definition and constant solution definition of things that sometimes work, that sometimes don't work. So our vision really for as an institution has been around how we elevate African voices. And we think that we do that by creating an army of experts, of African experts, and then making sure they're in the right places where decisions about Africa are being made. So that is really the background I'm in. And so the decolonization debate has come, but it has parallels to some of these things that we've been trying to do for a long time as an organization. And so where I sit, I see myself as first of all, somebody who is on the receiving end of a colonial system, but also now see myself as an African leader for different reasons. My age, I turned 50, so I consider myself old enough to provide wisdom to the world. But then also my positionality, I mean, my position, I lead an organization, so I'm in a position of leadership. And I think I've recognized that that comes with privilege. The stage of my career at which I am, I can take risks. My age, I can take risks. The position I'm in, I can take risks. And so making a conscious choice to use that privilege that comes with those three things for good, and mostly around advocacy for equity, but always going back to the African voice and also trying to understand who is the voice. Is it me? Perhaps, but in some instances, it's not me. And actually, as I think I've said before, that my biggest concern is that myself and my institutions and people like us don't become now sort of the gatekeepers to this power shifting that is hopefully coming from the north to south, and then we sort of keep it there at our own level. So, and so currently really what I'm trying to do in this whole discussion is to educate myself and understand how we got here, and then see how do we get out of where we are, because you're not in a good place. And so I'm doing a lot of reading to understand this, because understanding where we come from, I think, is the beginning point for figuring out how do we get out of, the current system that we're in.
Thank you. That's really helpful, because I remember being on another panel and there was a professor from Malaysia who was talking about having in-depth knowledge of one's own history, culture, the richness of our, as she put it, as our own history and culture as it informs public health. And I think with COVID, you see a mismatch when people just adopted solutions rather than look at localized solutions and worked within communities. That's really useful and helpful. I'm going to break it up a little bit. So Onu, you're, it's not last but least, but I want to ask Madhukar just to bring in a perspective from Madhukar about this question. Yeah.
Thank you, Sabina. I posted a piece that I wrote where I interviewed more than 10 people around the world on what decolonizing global health means. And it's in the chat box. What I've come to understand that it isn't a single thing. It means different things to different people. People who really are scholars of decoloniality will not agree that anything we're talking about is truly decolonizing anything. We also know that people who are privileged in the global north cannot be decolonizing or even thinking about leading anything. And much of the conversations are happening in schools of public health in the global north, which makes me wonder whether we fundamentally misunderstood what it is. But what I do appreciate this movement it's a bit like Black Lives Matter in 2020. It's not that racism is new, right? But what Black Lives Matter did was it opened the doors for anyone and everyone to boldly, bravely call out injustices, racism, white supremacy in all fora, and for institutions to react to it using various initiatives, or at least on paper, they are making pledges to do something about it. I think decolonizing global health is a code for something different. It's a code which says global health is extraordinarily inequitable even today. Not just when the time it was born and birthed in colonialism and supremacy, but even in 2022, every single aspect of global health, including this conference, is dominated by people in the global north. It's dominated by white people, it's dominated by men, and it's dominated by agencies and institutions that are pretty much participating in conferences like these. And so we know the diagnosis by now. I don't think we need even yet another blog post or an article on what is wrong with global health. Fundamentally, for a field that claims to be fighting inequity, the field itself is extraordinarily inequitable. There isn't an area in global health where you can say things are equitable. Grants, funding, partnerships, publications, global health courses, conferences, you name it. And honestly, I ended that blog post with tremendous skepticism that anything can ever be changed in global health, because for me, this pandemic is a lifetime lesson for me. I cannot believe that there is anything called equity in global health anymore after what I've seen in this pandemic. Rich nations have done egregious stuff, and we continue to hoard vaccines. We continue to deny countries an opportunity to make their own vaccines. And this has reached a point where we think privileged people here in the global north are declaring the pandemic over when you have 2.8 billion people completely unprotected. What BS is this? How do they get off making decisions for the rest of the world? And where is this coming from? It comes from the same supremacy that we know what's best for the rest of the world. So this makes me very skeptical, extraordinarily skeptical, that we as a field are even anywhere close to decolonizing anything. And I think if we want to change, then I think those of us in the global north and those of us who have that kind of privilege have to not only educate ourselves, which is like the first step, but actually do something about it to see the extraordinary power that we are holding and continue to have even today.
I think very powerful statements from everyone in different, we'll come back to this because we're going to also discuss some examples of what you can do, even if it's small measures, because I do agree with you. It's extremely frustrating. I want to bring Anu into the conversation because I know you're in an organization, you have to restructure, and you talked a lot about why it's so important to have, a different approach, even in organizations, and break down these hierarchies. But yeah, please speak to any of this or anything else that you think is important beyond IPAS or through the lens of working at IPAS.
Yeah, well, let me just start first by thanking you for inviting me to this session, and I look forward to the conversation with my colleagues here and with the participants. I think the phrase white supremacy has now been uttered, and I think that really is the key to a lot of this. I wrote a piece several years ago now, I think it's 2 years ago, White Supremacy in Global Health, and it was a blog post published in Think Global Health, and it generated a lot of interest. And I think it was jarring to see that phrasing in the context of global health, but that is what we're talking about. And I think, Catherine mentioned going back to understanding the roots. Well, those are the roots. The roots are very much steeped in white supremacy, and they are still, as Madhu was just saying, still very much present today. And I like to think about this being expressed in the way that I see it right now in three main ways. And I probably should be citing people. I probably have taken these ideas from Madhu and others, but I can't quite remember it yet. But these are not original thoughts from Anu Kumar. These are just thoughts that I have gathered together to put together in a way that's a little bit more understandable. I feel like this that white supremacy is expressed in three main forms. One is funding and funding flows. Where is the money coming from? Where is it going? How is it being regulated or monitored or tracked? And what is it paying for? I think that's also really important. The second is, I think, knowledge. What is considered knowledge? What is considered evidence? How is it generated? How is it shared? How is it disseminated? Who owns it? And ultimately, who actually uses it? So I think knowledge and knowledge creation and production is a huge aspect of how we see coloniality being expressed. And then practice. So how is global health practiced? Sort of in the way that it's taught in a lot of schools of public health, it's very much a diagnostic sort of approach. It's a very clinical approach, actually. If there's a problem, you figure out what the problem is, you diagnose the problem, you do an assessment, you figure out what interventions you should use, do the interventions, evaluate the interventions, and then repeat. And that practice of global health, which is obviously a very simplified version that I just gave, is replicated in numerous institutions, and in itself is quite imbalanced in terms of its the power dynamics in play. So to me, the conversation that we're having is actually fundamentally about power, and I think Sapna talked about values. And the values that are being expressed here are the values around who holds power. So who holds the money, who generates the knowledge, who actually practices global health, and who is part of that ecosystem of global health. I agree that the phrase decolonization is not helpful because it implies that there is an end. But colonialism is a 500-year plus process that we have all been a part of. No one is exempt from this experience, whether you're on the receiving end, as Catherine says, or you're on the generating end. I think actually everyone is part of all the ends, no matter where you're actually located. So I think that one of the phrases that I've been toying with is actually post-colonial, and I say that because it actually comes from post-colonial studies, which is part of a discourse that was created or really sprung up from the subaltern studies movement, which is in South Asia, which I'm sure you're familiar with, which focused on the power dynamics and the resistance to power. Those were subalterns, and that I think is really fascinating. And so I think if there's any hope, and I hear Madhu's skepticism and share it, because after all, what we're talking about is somewhat existential, to be perfectly honest, for global health. Post-colonial can be about really focusing on. So the hope to me lies in focusing on where are there points of resistance, where are there opportunities for change, how can we shift, alter the systems, even though they're quite large. And I can tell you a little bit more about what Ipas has been doing in our next round.
Thank you. That's just very, very useful and many, many interconnected sort of issues. I think, if we look at this, we're dealing with something that's so embedded and ingrained, and it's structural, it's systemic, it's so conscious and biased and subconscious and intentional and unintentional. You see this trickle down effects even within countries that embrace some of this rather than reject, push it, or challenge it, right? So we're all struggling in these spaces. I just wanted to get into, if from your own work or your own perspectives, what are the small ways, what are the struggles you've faced, but also what are the small practical examples or roles or measures you've been able to take to push back, be it curricula, be it teaching, be it research, be it within your own organization or some of the work you're engaged in, the alliances, the committees, or even through advocacy and writings. It'd be really good to hear from Catherine, and then we'll go break it up a little bit. Sapna, and then Madhukar, you're always stuck somehow in the third one. And then we go back to Anu, we'll break it up. But Catherine, I'd like to hear from you.
Yes, I think as I've said, a lot of what we've been trying to do for many years before, this whole decolonization debate sort of gained momentum was around defining what is equitable. So our work really was mostly around equitable partnerships. And we do have a definition of a partnership. A partnership includes conceptualization. And that's something which has been inculcated in us, that a partnership, a research partnership, is not one where there's money, that has been a result of conceptualization, elaborating the concept, getting funded, defending the ideas, and then bringing money to partner. So that is something which is fundamental to our ethos as an organization. And so understanding that and sort of explaining to people in the same environment. So we do a lot of capacity strengthening initiatives. We train PhD fellows. We bring early career researchers within our own environment. So that is at the heart of defining the role of the African academic or the African scientist. Your role is not to implement ideas. Your role is to conceptualize ideas. And once you miss the conceptualization boat, then you've missed it all. Because equitable partnerships really are about who owns the ideas, not who owns the money. Of course, the ideas follow the money, but we have to understand who owns the ideas. So that is on a small scale really what we've been trying to do. But then now,
Catherine,
increasingly,
just to ask you a little bit, sorry. So while you've been trying to do this as a leader of your organization, can you just give me one example of how you pushed back, or maybe, where a challenge or a struggle you faced, but you managed to say, no, this is important for us. And it'd be useful for those in the audience to, who aspire to looking at, these sort of injustices and hopefully want to change the paradigm and the systems that exist.
So I think I can talk about our early experience, my early experience joining this organization. We're a project-funded organization. We don't have a lot of what we call core or unrestricted funding. So most of our grants most of our funding comes from grants. You write grants, you win them, and then you get projects, and then you run them. And if you're an African institution, maybe in a month you receive about 5 invitations to partner of people or institutions who have received funding. So they sat down 1 year ago, conceptualized an idea, got money, and now the money is on the table. They've come to partner. And many times the partnership has been defined. So we're looking for a partner in Kenya to help us collect data, and we have $100,000. That is so typical. And so, as I said, when I joined this organization, we were struggling financially, really, really struggling financially. But we said no so many times to those forms of partnership, because that's not a partnership. My boss used to say that's a consultancy. It's not a partnership. A partnership starts from conceptualization. So take your money next time. Come back before you write the proposal. Come back when you have 1 page, bullet points. Then we can input, we can conceptualize together. And then we can define our role. We can define a role that is commensurate with our expertise. Then we can cost that role. So in a budget of, I don't know, £2 million, maybe our role is worth $500,000, not the 100,000 that you're telling us to take as partners. So that was, as I said, it was instrumental. And over time, we said no. Some people were shocked, some people were upset. But increasingly, this was the APHRC way of partnering, that we have to be on the table from the beginning. And I think it has served us well, because now we are able to claim, we are able to lay claim on the idea. We're able to position our staff in grant applications as either co-investigators or collaborators, because it matters. If the idea is conceptualized, you're not anywhere ever being a PI. Never, ever. It will never happen. Because the PI is the one who got the $2 million, and you, the partner, is the one who got 100,000 to collect data. You don't know how the data will be shared, where's the money for publication and all that. So over time, as I said, this has really served us well as an organization.
I can really relate to this, Catherine. We're just going through that, and I'm debating saying no, because there's so many assumptions about you're just lucky. It's building our capacity. They've decided it's $500,000. They want to give us 10,000 or 20. And frankly, I mean, there are times when I've said no, and then you're considered a troublemaker because not everyone else joins in, and other partners may agree to this. But anyways, that's very helpful. Thank you for that. Anything else you'd like to add, or maybe we move on to, because I wanted to touch on the journal you and Madhukar set up in terms of addressing some of that kind of research authorship inequities. But I don't know if Madhukar wanted to come in that conversation, because I know that was a joint thing. And then we can come back to you, Catherine. Is that all right?
Yes,
or did you want to add something?
Can chip in
Yeah,
here.
do you want to add something? Burning? You could please go ahead. I don't want to interrupt. I just did, but
No, I think I want to talk about something completely different. So I think maybe Madhukar can talk about the journal. But I could start by saying that I said earlier in my opening statement about the need to understand how we got here. And I think one of the things that perpetuates the current system is the knowledge system, because expertise, competence, credibility is judged based on the knowledge system. How many papers you've published, where you are in the whole, authorship, whether it's a paragraph, whatever it is, that feeds into a currency in which expertise is judged. And so in a way, the knowledge system is the one that is perpetuating what gets done, what gets studied. The curriculum is based on research which has been done about certain things. If you do research on HIV and show that HIV is a big problem, then it gets program funding, and then you do more research about this program. So those things are interlinked, but I think the knowledge system really is what's perpetuating this. And so understanding that, my contribution that Madhu can elaborate a little bit more is figuring out ways in which we democratize knowledge. Yep. Now we are approaching it from still the same, maybe broken system about what counts as knowledge. But I think over time, it is to try to understand how do we cascade acknowledgement of knowledge, acknowledgement of expertise beyond what has already been defined. Like you publish a paper and you're the first author. Therefore, your knowledge sort of holds more weight than a practitioner who doesn't have the journal as a platform. So for me, that is the long-term aim of democratizing, that we have many more voices that are not traditionally heard in the kinds of outlets that we have in global health.
Yeah, that's a very important point. I'm going to go to Madhukar and then Sapna, because I know she's been involved and engaged in creating that space, because there's a hierarchy and it's just keeps reproducing this sort of inequities and who are the knowledge bearers and who's valued. But Madhukar, maybe you could share a little bit, and then we'll go to Sapna and then Anu. And then Anu, next time you go first with the next round of questions. Yeah. Madhukar, please. Thank you.
I think we all know by now, based on a large amount of published research, that global health publishing is extraordinarily inequitable. For example, if you look at authorship patterns across many subfields within global health, it's invariably global north authors who are the first authors, senior authors, and most colleagues in the global south, if at all they are on the paper, they are in the middle, somewhere in the middle. And this has been proven again and again. So there's no need to even debate that. That's a fact, right? And that goes back to what Catherine was saying, that colleagues in the global south are seen as passive partners, not as active leaders who will lead the paper or be the lead author, so on and so forth. And this has a lot to do with global health funding. The fact that much of the global health funding, 80+% of Gates money, 80+% of USAID money, 80+% of Fogarty money, pretty much all goes to global north partners and institutions. And then it is subgranted to the global south. And the minute you hold the money, that decides the authorship and everything else that follows. So we know the diagnosis very clearly. So how do you challenge this injustice in who gets their name and who gets to present in conference? By the way, studies have shown that the exact same thing happens in conferences, right? Who gets to present, who gets to be on the podium? It's the same pattern all over again. So I was personally inspired by BMJ Global Health and what Shea Abimbola has done in terms of amplifying the voices of people in the global south. So when I was asked to provide input to PLOS, which was considering starting a new journal, I told them, if this is a brand new journal, are you willing to think differently? Because I first presented to them what's wrong with global health publishing. Then I said, if you want to fix this, you got to fix this right from the top. Firstly, if you have a high article processing charge, then that's not global health. You've already knocked off half of the world's population. So I find it disingenuous for journals to claim that they have a diversity, equity, and inclusion program, and then they turn around and charge you 10,000 euros as an APC. What bullshit is that? So they don't even understand what the term DEI means. You're knocking off huge millions and billions of people with those sorts of APC policies. So I said, if you're not willing to work on that model, then there is no global health journal. Secondly, if right from the top, from the editors in chief, if you do not have men, women, global, not global South partnership, there is no global health journal. The editorial board has to be women, has to be BIPOC people, has to be people from the global South. Every aspect of the journal has to be intentionally the reverse of what most global health journals are today. In fact, you got to do exact opposite of what a traditional global health journal is doing to swing the pendulum to where it needs to be. And I was delighted that they invited Catherine and me. She's in Kenya, I'm here in Canada, male, female. We are the joint editors-in-chief, and our section editors, we have 44 section editors. 70% are women, 90+% are BIPOC, and half of them are from the global South. And they are keeping us honest. We have section editors meetings every few months. We are active, vibrant discussion on, we go and solicit pieces from our colleagues and partners in the global South, including non-academics, including activists on the ground. We are trying everything possible to amplify the voices of people who are traditionally not seen in major global health journals, and nobody is turned away from the journal because they can't pay the APC. That's a written guarantee that there will never be anyone turned away from PLOS GPH because they can't pay the money. I cannot tell you how critical that was for Catherine and me. We would have walked away if there was ever a point when somebody, because everybody will be writing to us saying that you spoke about this journal and now we have to pay $2,000. That's not going to work for us. So all of this meant that it was an intentional project right from the beginning. And I think we were lucky. We didn't have a historical baggage that a colonial legacy journal. We had to think differently, and we started it last year in the context of all decolonizing global health, Black Lives Matter, women in global health. So we've intentionally done everything the opposite of where global health traditionally is. More women, more South, more BIPOC, in an effort to swing the pendulum in the different direction. It's a work in progress. We're not going to declare success, but we've been intentional about it at every step of the process. So when Catherine and I receive pitches for series or supplements, we ask, who's going to be authoring this? If this is going to be mostly people from the global North, we're not interested, right? Because then we are no different from any other journal. So the intentionality at every step of the way is what I think is going to be hopefully a path-breaking journal, but also the people that we have involved. To me, that is the sign that you truly have changed and made things different in the journal. Who is the brain trust? Who is going to be driving this? And how are they going to make it equitable is the challenge for all of us.
Do you want to name the journal? There's questions about the journal, so I'm going to let Madhukar share the name of the journal.
I put the launch editorial in our chat box.
But congratulations, one of my colleagues, Professor Masood Ahmed, is on your editorial board because, you know, I'm part of other editorial boards, so sometimes they have you on editorial boards, but the systems and the resources and the costs of publishing, you know, I can't tell you, being at BRAC University in Bangladesh, where we have very active researchers, half the time the research money doesn't allow you to publish. So you're constantly competing in this space where you have to keep up, you have to publish, unless you have equitable, meaningful partnerships, as Catherine was saying, which we have in a few projects where they actually provide funding to publish. They actually push for more varied, diverse authorship. But you have to occasionally remind them because it's almost sort of this sort of, you know, we were talking about privilege and power. So and sometimes we even have class privilege, caste privilege, white privilege. And I want to bring in Sapna here because I know you're working very hard to change sort of the way, you know, SRHM works on authorships and contributions and encourage sort of diversity of voices. Can you share a little bit, since we're talking about how do you create spaces? Thank you.
Thank you, and it's really encouraging to hear what PLOS Global Health is doing, Madhukar and Catherine. I look forward to seeing it. I'd like to share some of our learnings at SRHM, Sexual and Reproductive Health Matters, the journal's been around since 1992 because it was founded by activists right in the run-up to the ICPD, the International Conference on Population Development. It actually took on a different identity from the beginning from other types of global health journals. And strangely, we don't get categorized in the global health journal world, and we probably should in that way, because I think some of the things Madhukar has mentioned we've been doing for many years, and not without many challenges. And I want to share some of those challenges. So the journal's been around since '92. It was published in 5 languages for many years, in full publications with editors in different parts of the world doing the language translations and editions, choosing appropriate articles. We have had the majority of our authors from the Global South, lead authors. We have a really interesting mix from, I think, inception of not just traditional academics, but a lot of practitioners and practice pieces and activists and advocates working on sexual and reproductive rights. How did the journal get there? And I think that's really where the question of investment lies, because it is an investment, and it's really about putting your money where your mouth is. And I'll give a very specific example. Sundari Ravindran and I are right now co-editing the first South Asia special issue. The amount of time it takes to do what I just said, to ensure that almost all of our pieces are first authored from authors from South Asia. And given very different backgrounds and experience in this type of writing, means that as editors, we put in work that I know would not be possible had the journal not actually financially invested in that. We also brought on mentors who actually are working with activists and different types of researchers across South Asia to bring pieces to fruition. We've done roundtables, for example, with practitioners to allow their voices to be heard in different ways. All of this really is a lot of time, and it's a lot of investment. So I think it's important for journals, and journals really are the interface. Listening to the conversation earlier, I kept thinking, a lot of this doesn't really affect me in my day-to-day life, the decolonizing conversation, to be very honest, sitting in India. When you go about doing your work and really just trying to get your work out to influence policy, for example, or programs in country. But the real interface is the journals. And the real interface is when you see who gets to create that knowledge and to interact with the world. And I think SRHM has helped create a space for those working on sexual and reproductive health, because it has had the support of many funders who've understood that mission. So this is really an open call also to funders. I mean, most of these journals work on a revenue model that requires either APCs or, other subsidizing the functioning of the journal, and they're not editors who have the kind of time and, who need money as well, I suppose, to support an editorial team. So if we want to see those type of changes in journals, having now just gone through it for several years, it takes investment. It really takes putting money where one's mouth is, and it is possible to do it. And I think I'm really proud to say, we have created a journal that publishes things that no one talks about because they're not mainstream funded, as you know, Sabina, in SRH. But that's because funders have really put in the support, in the journal has stuck to its guns in rejecting articles that are otherwise technically very sound, but written by a bunch of people who don't work in country at all. And we don't do that out of principle. And I want to make this last point. It's not the principle of only where someone sit. It's what makes a good article. What makes a good article? It's someone who knows how to ask a relevant question, and somebody who also can interpret their findings or their perspective in a way that is relevant to that local context. And I would argue that's actually impossible to do if you're not deeply embedded in a context or have very deep and strong partnerships in that context. And that's why those are the journal articles we choose to publish.
I mean, I take my hats off to Madhukar, Catherine, and then Sapna, and I'm coming to you, Anu, because what it takes is commitment and passion and deep sort of belief in that this is important. And we're going to get to the next question of why is this important, but I wanted to come to Anu now, because you've been deeply committed and you've kind of been a disruptor, if I can say. Ipas is a very good, well-established organization. You've been there and you came in and you disrupted the sort of status quo. And that has actually improved productivity, improved engagement and ownership, and it's also created its ripples. And I wanted you to share a little bit more, because I think that's important to be disruptors. I work with a couple of disruptors, and I'll come to Bangladesh later with our curricula, but I'd like to hear from you, Anu, to share with all of
Sure.
us.
Yes, thank you. And very interesting to hear the other examples. So yeah, I've been actually with Ipas for 20 years now, and so have a long history with the organization. I've been CEO for almost 4 years, and actually my being CEO is disruptive, because in the global health institutions, there are very few, as Madhukar noted, women of color who are CEOs. And so just by being here and being in my position, it is unusual. And I think that, combined with the Black Lives Matter movement, the inequity that was really obvious during COVID and still is obvious during COVID, all of those things really made me think about not just my own role in upholding white supremacy, how I have benefited from it personally, but also what my institution does, how Ipas is part of that system. So I was listening to Madhukar's description of the new journal, and realizing that part of the challenge that we've had at Ipas is that we are nearly 50 years old, and we have a lot to unlearn in the way that we have been working. So while we are trying to be as intentional as possible in living through our values and thinking through all of the steps, it's hard, because I've been with the organization for a long time, and the institution just has its way of doing things. You know how institutions have their own sort of culture, even though obviously it's people that make that culture, and we can change it. And so what I've started off, and this began almost 2 years ago now, is a process that we're calling internally the Ipas Roadmap, and where we looked at what was a very traditional hub and spoke model of an INGO, of an international NGO, where we had a headquarters in the US and we had these satellite offices in our countries, right? And they were our countries. And and unlike, I would say, most other international NGOs, Ipas always has had local staff in our country offices. So there are no expats, there are no third-party nationals in our country offices. And while I think that's been really beneficial and helpful, I have to say that I don't think being an urbanite in wherever, Nairobi, Delhi, Mumbai, wherever you might be, is quite the same thing as being from one of the communities in which we're operating. So even there are power dynamics, and we have yet actually to address those. We are getting there, but we haven't really addressed those yet. So we looked at our structure and thought, okay, this actually is the epitome of hierarchical organization, right? Everything kind of funnels up to this chain, through this chain of a command that goes up to me as CEO and then the board of directors. So we decided instead to adopt a networked model. And in a network, which is a much flatter organization, the US office becomes one node or part of the network on the same level as every other node of the network. And nodes are not necessarily entirely defined by geography. They can also be defined by technical skills or program management skills, which again, don't have to live in any particular place. They can be in different places around the world. They can be in one location. They can be in multiple locations. So the possibilities that exist with the network are actually, frankly, really exciting to me. And I find them organizationally to be really interesting. And we're just beginning that process of learning. We also adopted a management style or approach called shared leadership. And instead of beginning, so shared leadership is the idea that decision-making is going to be done at closest to where the work is happening. And those that are involved in the decision, or those that are going to be impacted by the decision, are involved in the decision itself. So rather than it being based upon positional authority and power, it's based upon your connection to the decision at hand. And so this has been really interesting. And we didn't do this by like doing some kind of radical structural change immediately. What we did, and I think Sabina, you and I share the fact that we are anthropologists, culture is based upon behavior, right? You change culture by changing behavioral patterns. least that's one way you change culture. And so one of the things that we decided to do institutionally is to change small things, small and big things, but start by changing behavior. We're coming to the structural question soon, but we didn't start with the structural question. So we changed, for example, I'll just give you one example and I'll stop. We changed the way we allocate resources. So remember, going back to that question of what is, how is colonialism or white supremacy impact, shown in institutions? One of it is through money and funding flows. And that exists even within institutions that receive external grants, right? So we have funding and resources within IPAS that are then allocated throughout the IPAS network. Typically, decisions about funding allocations were done through this hierarchical model where some version of executive leadership made decisions around money. Well, we decided to change that, and we did it. We've done it now 4 or 5 different times using essentially committees of people that are involved in the decision themselves. Executive leadership is involved if it is relevant. I am not involved in those decisions any longer, which, to be honest, has been incredibly liberating. Because it always felt deeply uncomfortable to me to make decisions about countries and places and skill sets that I actually don't know very much about. So, making a decision about what's happening to the Zambia office felt always very scary to me because I don't know Zambia. That's not a place that I've ever been to. So this has actually been in somewhat quite liberating, I think, for leadership, but also very empowering to staff because they are involved in decisions and are seeing the entire financial information of the organization and how decisions are made and what's the balance that needs to be struck in making these kinds of decisions. Importantly, every decision, the criteria for the decision making and the outcome of the decisions is shared transparently with all staff. Immediately. So those are some of the things that we're doing to change. We have a lot more that's happening that I can talk about later.
Just listening to all of you, I really think, it's very transformative and it's so important. And I have a quick question, and you can give me a brief response, and then we're going to address the 2 questions in Q&A and then go to another round of conversations. But I'm just wondering, because something that you're saying unpacks, I guess critically challenges most agencies and approaches. If you look at most organizations where people fly in, they make policy recommendations. You've got consultants, there's a whole business of consultants. You've got a business of parachute researchers, even from, different countries and even within countries where, as an urban who's never been to a rural, making decisions around. So there's all these layers of power, privilege, and privileging of certain kinds of knowledge. How did you even get to push this forward? I mean, the board, the trustees, because I'm curious, because I don't work in I work in a university and I know the challenges there, but it would just be good to get a bit of insight.
Yeah, well, so thank you for that question, because a key point that I should have made is that the roadmap, this work that I'm describing, is really about our operational model, right? What's our organizational operational model? Well, that follows what is our strategy and our mission. So the why of, why does IPAS exist and what do we do is answered in our strategy. And we took an approach 2 years ago where we became even more deeply committed to local abortion ecosystems. And we took an ecosystem approach where we say, if we want to have sustainable abortion care, we need, and we have a very rigorous definition of what we mean by sustainable abortion ecosystem. We need these 8 factors, okay? But IPAS can only do a few of these things. We're not good at all 8 of them. We're good at maybe 3, sometimes 4, depending on the circumstance. We need partners. And by partners, I don't mean just community partners, I mean government, I mean a whole host of partnerships that need to be involved in creating this ecosystem. And in order to really understand the ecosystem, you have to have deep knowledge of that location. And it can be sub-national, not just national, but sub-national or regional. So that, the why, and how it connects to our mission. The mission is about reducing harm from unsafe abortion. So that, we believe, can best be done locally, contextually, and still connecting back to a global movement. And so one of the things early on that I was really struggling with and then continue to is, I really do not want to be trapped in a dichotomy. I am not interested in a conversation that talks about global North versus global South. That is, I think, not a helpful way of approaching any of this. And so we have to think about how we can all work together, knowing the kind of deep power dynamics that exist and how to mitigate those power dynamics. So all of those things came into play, and the conversation with my board was in that context.
Thank you.
Sabina,
Madhukar, you wanted to add something.
Yeah, I
Please
just
come
wanted
in.
to provide some interesting experience that Catherine and I had, which I think is extraordinarily illustrative. So when PLOS Global Public Health launched, there was an open call for anyone who wanted to be on the editorial board, wanted to be an academic editor. And guess what? When we looked at the incoming applications, predominantly men, and predominantly from US and Europe, right? So we obviously had to pause that. And intentionally, that's why, Sabina, I ended up writing to you saying, please give me suggestions of editors in Bangladesh. You know, I've written to people, Catherine did. And so we had to work extraordinarily hard to push this pendulum away from mostly men, mostly US, Europe, to where it is today. But even today, I can tell you that it's a struggle, because the pendulum invariably swings in global health to the global North and to men and to white folks. And to disrupt this, you have to expend like 10 times the energy. If you did nothing, that's where everything in global health ends up. It's like the great attractor that pushes everything in global health towards that. And you have to work so hard to push it in the other direction. So if you stop pushing, then it swings like almost like magic. It swings again towards where it needs to be. So even now we keep looking to say, who are our authors? Are we still, you know, mostly men? We have to keep on pushing and do additional recruitment and commission articles to push it away to where it needs to be. It's like an everyday struggle and battle to keep the journal aligned with its mission. If you stop, it just goes in one direction. And I think that's very telling. I think if Anu stopped, it might well go back to where Ipas was some years ago, because it's an active process. Equity, diversity, and inclusion is an everyday work. It's not something you do once and you walk away and come back after 2-3 years. It would stay the same. It just cannot.
I was just having this thought about, that's why alliances or allies are so important. Otherwise, it can be a very lonely journey. If you're deeply committed and you see this, the veils have been removed. But I'm going to go into some of those questions that have been posed. So one is, very quickly, I think Madeline Finkel saying, how do we change the situation? I think what we heard was really concrete examples from Madhukar, Catherine, Sapna, Anu about changing systems by having journals that actually don't do the same old, create diversity of voices, spaces, give support, deliberately have preferences for authors who've worked in those sites and countries and can write richer, more in-depth sort of evidence-based sort of knowledge. And Catherine talked about just saying no to funding that has no discussions prior to what the project's about, the assumptions that I will just partner with you, here's some money. But I want to go to some of the other questions and then do a round. So one is, that's just a comment that how do we change, you know, high income universities if we look at academic promotion criteria based on first authorships, PI on grants, conference presentations. Like, if we want to look at equity as an issue, how can this be achieved? For those who are comfortable in academia, anyone can respond to this. I'm just going to read out the 3-4 questions. The other one is about how important, you know, it's like, you know, someone says, in the context of ensuring that research in global health is published by authors from LMICs, how important do you think it is to talk about what global health is, given its history and ill-defined boundaries? How might the work in expanding access to publishing global health be combined with or create the need for further conversations in defining the field of global health? And then Amit, hi Amit, how are you? I worked with Amit on another humanitarian panel what should be done more in universities, and I would say organizations as well, Anu, from your example, or agencies, Sapna, or even in these different sort of institutions in the global north in terms of training curricula, but even in maybe countries like Bangladesh or India, other spaces, I can share a little bit, but to ensure that the next generation of global health, public health professionals work in a more equitable, respectful manner, but I would also say are capable, and there isn't a mismatch, of capacities. And I think the last one is, oh, there's quite a few. Sorry. So let's go with these first three and have quick responses, and then we'll go to the other two. Anyone, please raise your hands on the little reaction face thing. And then I can, you can speak to any of the questions, one of the questions from an organizational university institution perspective. Sapna, thank you. I was struggling there. Sapna, you had your hands up. Yeah.
I'm going to make an overarching statement that I think addresses a couple, which is, look, until I think global health or universities of public health, most of them in the global north, but also in India and Bangladesh, need to value practice. They need to value context is not something you gain in 2 weeks in an internship. It is to gain that practice and to really have that knowledge, it needs to be valued. I would not let a doctor touch me who hasn't done a residency. I'm not sure why somebody gets to be a global health expert without actually ever having worked in a different setting, which is quite common. So to me, I think that just, valuing practice and humility. I mean, it's not something that can be taught, but the idea of what an expert is and who an expert is. I mean, I'm astounded by the number of lectures we've been given by, parachuters who come in and, give you a lot of knowledge about things that they may not have much context on. But the point is it's humility and really who is the expert, and that we all have something to gain and something to learn. So those two things within universities, I'd like to really see change.
Absolutely, and so honest and so true, and I live it all the time. Well, and accountability for this sort of really unethical, Okay, so Catherine or Madhukar, Anu, any kind of responses? Catherine, yeah.
Yes, so it's a point I wanted to make earlier about some of the key players in global health as we know it, and I think some of the comments have alluded to the role of funding agencies, and because the incentives in the system really, some of them are perpetuated or are provided by funders. Because if a funder is interested in how many papers you published and in which journal and what's the impact factor, if that is the incentive, if that is the reward, then people are going to do that. And it goes back to the point that Anu said, that culture are the things we do over and over and over and over again until they become the norm. And norms are perpetuated by rewards. So when you think about the law of I don't think it's even the university. The university doesn't need to do anything. The funders themselves can cut off the tap about these sort of incentives that perpetuate this. So rather than rewarding X number of papers in which journal, they could reward, okay, so what? You've been in the practice for 20 years. Can you say just one thing, that your work has led to, that you changed something, you changed practice, you changed, because I mean, I get animated about this. You can't have 200 papers and you can't point to one single thing that your research for 20 years has changed as a result of 200 papers. And you want to add more 40 papers for what? What is the end? Like, you can't publish papers in perpetuity without pausing to think about, so what? So the reward system from the funding agencies can change. And what I've seen, what I've observed, there are things which have started to change, for instance, about that good research is not only defined by the study methodology and how robust the sample size computation. Yes, that earns you marks, but is our partnerships equitable? What is the capacity strengthening plan? Is it tokenistic? What is the community engagement and participation in the research? So that we don't keep on doing the same thing. Good research, good for who? Who defines good? Like, you're going to publish 5 papers. That's not good enough to define what is good research. So funders have started putting those metrics in there. But I think for me, success will be when we get to the point, I think that's what Sapna just said, metrics that quantify expertise other than how many papers are published. If I've spent half of my time meeting the Minister of Health to change one thing, that should count for 20 papers or something, so that we can get, because we spend so much time meeting after meeting after meeting with the Minister of Health and every technocrat to change something. Or practice, if I've practiced, quantify that. So we can say, okay, on one side, 20 papers equal to practice, 20 papers equals, so then we can get on the same footing about what qualifies as expertise. So that's what I wanted to talk about. Now, the last part was about what needs to change in the curriculum, because I think the curriculum is focused on the content, the theories, the frameworks. You know, I think somebody said that, yes, this is a problem, this is how you define a problem, this is how you solve it. So it is focused on that. So I was trying to find parallels, like in the social determinants of health. So I think if I was to find that, if I was to use that as an analogy, it's like the curriculum is focused on the small little circle about what you do as an individual, and it needs to broaden to the history. How did we get here? Self-reflection. Why are you in the master's program at Johns Hopkins? Why are you there? If the reason you're there is to go and save some person you've never met in another part of the world, maybe you're in the wrong profession. But that can only happen if the curriculum itself, not just the curriculum, but the lecturers, the format, the what, has people who can come and articulate some of the problems with the coloniality model, with the supremacy models and all that. So the curriculum, I think the frameworks are great. I mean, but somehow these frameworks need to be contextualized with everything else that's happening, the political system, the geopolitics. I think those things are what's missing, but really opportunities to self-reflect about our intentions on why we want to get into global health. I think that should be like mandatory. Maybe do a questionnaire, say, why do you want to do global health?
Absolutely.
And then address them as part of the curriculum.
I think critical reflections, humility, unlearning. We'll go to Anu. Yeah, please.
Yeah, thanks so much. I just wanted to respond in, I think, two ways to some of the questions. The first is to build on what Catherine and Sapna were saying about incentives. And we, kind of had this conversation a little bit earlier as a group, but I think incentive structures really need to be changed. And that is very much deeper than what any one of us as individuals can accomplish. Though those of us who are in leadership positions certainly can make those changes because we do have the power and authority to do so. And one of the reasons that we're making the changes we are making at Ipas is because I am in charge of the organization and I'm making these changes and are bringing people with us, so you can't control everything, but you do have some amount of control over your own little world. And so the change, I think, into incentives also needs to be considered. When I think about the incentives that are in place for CEOs, they are really about expansion and growth and fundraising. What is considered a good CEO is a person that can raise money. And of course, that is important. But as Catherine was mentioning, has your institution done anything useful lately? Should also be a good question to ask. At Ipas, I'm very proud of the fact that we've been involved in so many different law changes relating to abortion and abortion care, literally impacting the lives of millions and millions of people around the world. That's not one person, it's institutional impact, but that's the kind of impact I feel like we should be measured for or against, those kinds of changes. Also, is Ipas helpful in the broader movement for women's rights, for human rights? What is our place? And so one of the things we started doing several years ago was to actually assess how we behave and perform as a partner. Because we talk so much about partnerships, but we never actually then say, okay, well, does anybody like working with us? How could we improve as partners? And so we started asking our partners, what do you think about our partnership? And we've gotten very helpful feedback, about the things that we need to improve and things that we need to strengthen. So anyway, I think a critical look at incentives is really important. And then to this other question around training of global health practitioners or students. And I had a recent conversation with the University of North Carolina at Chapel Hill. Their program had a discussion about how to adapt their curriculum in response to this conversation on decolonization. And one of the questions I think it's really important to answer for people who are entering this field, particularly from the global north, is what is it that only I can do or we can do? which is actually a very small list. And so, and I think it may include, for now, knowledge curation, collation, and dissemination. Not necessarily knowledge production, but curation, collation, dissemination, because of the facility that we still enjoy in the global north to the internet, to our access because of our resources to journals and books and things like that. I don't know if that's just an idea. That's an idea. I'm not sure that's a forever thing, but the question I think is the one thing to ask. And this is actually something that an executive coach told me years ago when I became CEO. What is the thing that only you can do? I know if those are the things that you as CEO can only do, then you should do them. If anybody else can do those things, then they should do them. Why are you doing those things when you have other people that can do them? Good point. So I think it actually translates to this conversation. What is it only we can do?
Great. Madhukar, you had your hand up. Did you want to add anything?
So I'm just trying to respond to some of the questions about, so what
Yes.
can we do about this problem, right? So now I'll speak to the piece that I've been thinking a lot about allyship. I started thinking about allyship because I learned early on that men dominate global health, right? Every aspect of global health is dominated by men. So I asked myself, so what do I need to do as a male in global health, right? What is my role of being an ally to women? Now, along similar lines, white people dominate global health, every aspect of global health. Now, what is it that they need to do as white people to be allies to Black, Indigenous, and people of color? What do white women need to do to be allies to BIPOC women, right? And the list goes on and on and on, because global health is extraordinarily skewed. So to those of us who are extremely privileged, from whichever intersectional lens you would look at, global north, high-income countries, men, white, you name it, we have a massive task ahead of us that if we really care about inequities, and if we want to do more than do lip service, then we have to learn allyship and practice allyship. And that means literally ceding space, power, resources at every stage, and do this on an ongoing, continuous basis. So the piece that I wrote, which I posted a link to, offers a lot of concrete suggestions from various people from around the world on what allyship means to them and what is it that we need to be doing. And what I will say that it's very hard to practice allyship, and it's even harder to go beyond that to be a co-conspirator to disrupt the current ecosystem. So for example, if we are talking about wanting third doses or fourth vaccine doses for ourselves here in the global north, then asking for more vaccines to be shared would be an act of allyship. But what would be even better is to advocate for the TRIPS IP waiver so that there is no need for charity anymore, that countries are self-sufficient in whatever they need to produce. John Inkingasong, the Africa CDC director, had a lovely piece in New York Times yesterday, where he says he truly wants to see self-sufficiency in Africa so that they're no longer in this nightmare situation where barely 15% of the continent is vaccinated and vaccine trickle down is happening over a period of 2.5 years. And I think that is where our future lies, that we disrupt the systems so that white saviors are no longer necessary, that we don't need high-income country people to dictate what needs to get done, that would make for a truly equitable global health. But my biggest problem is nobody wants to cede power, right? You have all of these webinars on decolonizing global health and global north institutions. You have all these DEI institutions where a token Black person is hired or a token Indigenous person is hired. But then fundamentally, they are not ceding an inch of space, power, or voice, and unwilling to pass the mic on, which I think is deeply problematic, which tells me that they do not understand the first thing about what decolonizing truly means, because they've not understood what their role is. They still see themselves as leaders. Every aspect of global health, they see themselves as leaders, not as allies. So where is humility, what Sapna said, right? Where is the deep sense of reflection, right? There is no reflexivity when all you want is get more and more real estate. So we have a ton of work to do, men, white people. If we don't put in that work, just like anti-racism, you can't become anti-racist overnight. You got to put in that daily effort if you truly want to be anti-racist. And it's not going to happen by just hiring one Black person and declaring that you've done the anti-racism work.
This is excellent. I'm going to go to Sapna very quickly, but I wanted to add to the School of Public Health, where I've been for 19 years. You know, I remember in 2016, a collaborating colleague, a learning design consultant, Mikhail Islam, pushed me because I did a lot of research on structural, social, intersectional, human rights, social injustice. And he said, you know, the curriculum, even though we have a lot of experiential community-based learning, he said, why aren't we looking at local solutions from communities? Why aren't students, because we have students from all over the world, why aren't they engaging with the communities? We're looking at community-based health outcomes. And we started piloting, and there was some level of resistance. And because I was in that position of being a dean, I'd taken over in 2013, as Anu was saying, it gives you that space to push. And even with research, I've pushed back. Can we discuss tools that are co-created? Its authorship and data sets belong to the school, because we have colleagues, we're not data collectors. And I think these are little ways we can do things, but there's some bigger questions being asked. And some of them are just sort of, if we're part of this whole colonial system, it is so embedded by participating in these, let me just go to the question and answer. It's sort of very, but it's like, how do we kind of create those kinds of changes? I can't seem to find the rest of the question. Sorry, there only seems to be one, but really, I'll just read through this. Very inspired. To what degree can these changes ripple out and affect change in the greater world system that is fundamentally colonial in every sense? And I think the earlier question also referred to this. To what degree are we limited by these constraints? In other words, what power do we have towards decolonizing one system within a world framework that is entirely colonial? So very quick responses, could be 15 minutes. And then I wanted to end on a sort of a, hey, ways forward, because I do think all of you epitomize. I also think the BRAC School of Public Health in its own way, working with colleagues and partnerships, are making shifts and changes. But of course, the structure and the embeddedness of what we're up against is, you know, it's huge. But let me just start with maybe Sapna, and then we go to Catherine, Anu, and then Madhukar. Is that all right? Yeah.
I just wanted to say one thing, and it's just speaking to what both Madhu and Anu said earlier. You know, a lot of this, I wouldn't say can be resolved, but certainly can be addressed by true partnerships. But I think true partnerships really require going the distance. And I will say this because I think there are a lot of students probably listening. It's really hard. It's not something that you can do in a week, in a month, or even in a year. These are partnerships that require humility, a lot of hard work, but also feeding space. And I think a lot of people's worldviews and understanding will change when you're actually in a situation where you realize you can do nothing. I remember right after my first degree, I walked into a primary health center in rural Gujarat, and someone asked me to like help, and I looked at them and I said, I don't know anything. I mean, what could I possibly do here? And to be able to say, I don't know, and I'm not an expert, to me, is a beginning of understanding why partnerships are so critical. And I'm sorry, I'm not responding to the colonization, because I think Catherine and Madhu will do a great job on that. But I just wanted to say that, look, these partnerships are difficult. They're hard, and it really requires going the distance, which very few people are willing to do because it's just not convenient.
I keep muting myself. Thanks a lot, Sapna. So maybe, yes, Catherine, then Anu, and then Madhukar. Yeah, thank you.
I wanted to say that when I saw that question, I was like, oh boy, because when you start making the connections and you realize that these are power systems, and so this is a symptom of power systems, it can be daunting, because it's almost like, is it even possible to make a dent in this system? That's one way of looking at it. But the other way of looking at it is to say, okay, at least there's some kind of awareness in this one part of the system around global health, that there's that kind of awareness. Of course, it's spreading to global education and all these other areas. But I think global health is well placed to do something. So sometimes I tell myself that maybe we are going to tinker on the edges and eventually the system will collapse, or maybe not. but I don't think it's an option not to do something because it's so hard. I'd rather go and fail and say, okay, I tried and I failed, or maybe go and succeed, who knows? Because 5 years from now, we might look back and the system has been changed and the system has been transformed. And maybe not the whole system, but parts of it. And so for me, that's what keeps me going, because sometimes you can look at this and oh my God, this is hopeless. So I want to do the things that are within my power to do and try to make changes in those areas. And then hopefully you get allies all over the world, and our collective efforts maybe will topple the system, maybe not. But at least I will try. And hopefully there are others who are willing to try and look back on our deathbeds and say we failed. But before then, I think we cannot not try.
I think nudges and these are steps in the right direction. So everything counts, everything matters. And it's sometimes between despair, but I hope lots of hope. So Anu, and then Madhukar.
Yeah, I think it's an excellent question. I think that, the question asks, what are the constraints, or what are we, are we limited? Definitely we are limited in what we can do. And I can see it within Ipas as well. We certainly have, are able to make changes within our own, things that are within our own control, but we quickly bump up against, particularly in the donor landscape, ways of thinking and behaving that are really reinforcing some of the power dynamics that exist in the global health architecture. And one of my most common examples these days is about compliance, financial compliance, which is not a very sexy topic, but I do think that financial compliance and how rules about money are imposed upon grantees, and there are a different set of rules whether you are located in the US or Europe, or if you're located in Africa or Asia, because it appears that there's less trust in organizations and institutions that are not based in the global north. That's a pretty big problem, it seems to me. Now, it can't just be undone with a magic wand, because many of the bilateral donors, for example, are doing what they think is best because they are spending public money. And they feel, then it's not wrong, I think, that they have an obligation to spend that money wisely and hold everyone accountable. But it creates these, these power dynamics, and it makes partnerships even more challenging, as Sapna was saying, because it puts power, not just the monetary power, but other kinds of power in the hands of the institutions that's receiving the money. As Madhukar said, 80% of those resources are going to institutions in the global north. And that's partly why. It's partly because of compliance and the need for accountability. So, we hit upon that immediately in our attempt to remake our organization. And that's sort of beyond our control as an institution. There's very little Ipas can do to tell governments around the world how they should, spend their money and how they should account for their money. Nonetheless, I do feel a bit like Catherine, that now that I see my role and Ipas's role very clearly, and even more clearly with every passing day, now that I see our role in upholding these inequitable systems, I can't unsee it. I can't now say, okay, well, never mind, I'm not going to do anything about it. So yes, Mitra, you're absolutely right that these systems are really challenging, and we're not going to do away with the entire system. And we still have to do something about this. And this is sort of my way of doing something about it.
Yeah, thank you so much. Madhukar, you have maybe, I'll give you 5 minutes, and then I thought this was excellent. I really, it's great to have these discussions. I really think it's critical, it's timely, but we need to kind of keep pushing the powers that be who need to be accountable. Because, token representation and webinars and seminars are not sufficient. What are we doing about curriculum, about research, about allocation, about meaningful partnerships? And how do we get together, as Catherine was saying, in different ways to push back? But Madhukar, we'll end with you, and then I'll just thank everyone.
So, whenever I'm depressed, which is a lot these days, given how terrible the world is headed, I turn to young people for inspiration. So a week or 2 weeks ago, I wrote to people, young people around the world, and I asked them, so what do you think the adults are doing in terms of how we are performing with the climate crisis and pandemic, right? By adults, I mean all of us here on the panel. Oh boy, they just tore us into pieces with their criticism. Please read that piece. The Forbes piece link is in the box. Consistent response from 24 people around the world, and it wasn't pre-planned. They did not know that I was contacting anyone else. They just shredded our global response to the pandemic and to climate crisis by saying that adults are simply failing at every stage, that there is no global solidarity, that there's just shameless nationalism on display, tremendous greed, unwilling to look beyond our next election or do the right things for what is necessary. And they all feel that their future is truly jeopardized by current leaderships and by current initiatives, which are simply not in line with what they're thinking. And when I asked them, so what gives you hope? They didn't point to any leaders. They didn't point to their professors. They said, we are taking hope from each other, from other young people. And they're saying, we believe that we are the ones who can change this broken global health, because we're not seeing anything enlightened coming from any leadership. And they're all willing to jump in and do something that is just and equitable. So to me, I was just absolutely blown away by the consistency of their response. And I think if we truly want this broken global health to change in any meaningful way, encouraging young leaders, especially women, especially young leaders from the global south, to play a bigger role at every stage would be a path forward, because I almost feel like that these are existential crises. And we've already seen such egregious failures. Imagine a war in the midst of a pandemic. I mean, what kind of rubbish is this? And who will do this, right? Again, it's men who do this, but this is just to say that we have an incredible amount of work ahead for, I think, for all of us who are in positions of power or privilege. Anything we can do to give leadership roles to young people might be a path for salvation, because I cannot see us, if you use our performance in this COVID pandemic as a yardstick, and I think they would all give us an F- if they could grade us. I don't see hope for the climate crisis. I just don't see it. And I don't see any enlightened leadership from anywhere in the world, especially among the adults. Adult men, forget it. It's not going to happen. So if you want to jeopardize the whole planet, or you want to not jeopardize the whole planet, we've got to find creative ways of leaning out and just ceding the mic to people who can actually do something about this crisis that we are in.
Thank you so much. For me, it's been an honor and privilege to moderate and having all of you share such, critical reflections, concrete work you're doing. One thing I'm left with is, as we look and talk to each other, and some of us will engage in work, is that, we've forgotten the human being, the universal shared humanity, and why it's so important to make a difference. We're all in public health to what? Not to be, saviors, but to really work across with partners, work with communities, understand it's diverse, work with, countries that are not defined by their geographical locations. So there's capacity building for some, and the others are the knowledge bearers. And I think that, and Madhukar, you talked about the war, universal sort of ideals and values, ethics and accountability, and a shared humanity where, 2/3 of the world don't even have vaccines. So what does that mean for our new leaders? And I think many young people, and what I'm seeing in the chat boxes, many of them have enjoyed these discussions. And as Sapna said, there are spaces, we can, students, the young generation can actually challenge and start shifting, I hope, some of these sort of embedded structures, but it's a long road ahead. And I just wanted to say, given 1 minute is left, thank you so much to CUGH, but especially to my expert panelists who made time. It's very late in some places, very early in other places. Stay safe, stay well, and thank you very, very much.
Thanks, everyone.
Bye-bye.
Thank you, Sabina.
Thank you so much for having us. Bye-bye.
Bye-bye. Thank you. I think we'll just wrap up now. Thank you.